Good evening, all. A warm welcome to you all on behalf of SAPC new team for 2023-24. This is our first month meeting scheduled as a webinar. We are privileged to have speakers from SAMS, that is Society of Anesthesiologists, Maharashtra State, on the case-based themes. I welcome Dr. Balaji Asegaonkar, President of SAMS, Dr. Anita Nehte, President-elect of SAMS, Dr. Avinash Bhosle, Vice President, and Dr. Rajesh Tagadpalle, who shouldered the responsibility of Secretary of SAMS. I thank all of you for giving your valuable time from your busy schedule. I also congratulate newly elected office bearers from National ISA. We have two eminent speakers, Dr. Balaji Asegaonkar from ISA Aurangabad and Dr. Anita Nehte from ISA Nashik. A topic chosen by Dr. Balaji is that no postgraduate exam board students will appear for the exam without knowledge and the faculty facing the problem of cardiac patients for non-cardiac surgery. Another speaker, Dr. Anita Nehte, will enlighten us on anesthetic challenges of the burns patient. She will try to take us through the acute burn management as well as challenges for the burn contractures. Greetings to you all, both sir and madam, and greetings for the Diwali occasion. A little about our branch activity. As per SAMS guidelines, we quarterly release our bulletin e-pulse since last 2 years. Nearly 10 to 12 editions are been published till now with a feast of topics in each. We had successfully arranged National ISA sponsored CME in collaboration with D.Y. Patil Medical College, Pimpri, and at the same time, we also conducted the simulation workshop on the high-risk obstetrics by Dr. Sunil Pandya and his team from the Fernandez Hospital, Hyderabad. Currently, our many faculties took part in the chairing session and arranged Art Katta exhibition at ISACON Maharashtra 2023 with separate souvenir on it by Dr. Maya Bhalera, Shubhangi Kothari and Dr. Sumit Lad. We conduct separate meeting on the cultural activities along with the members' picnic and with their family members annually. We actively participate in the scenic program Diwali Pahat arranged by SAMS, tree plantation and the Doctor's Day celebration which was conducted on the 1st July every year. Ours is a vibrant branch with maximum goals activities and the public awareness social outreach tasks. We have active participation on the Facebook page of MSc ISA from time to time. We reach to all members and appeal them to be the member of FBF, that is Family Benevolent Fund, for those who are eligible for it. In the future, we'll have various meetings in the physical and arrange more and more academic CMEs as well as the workshops along with the cultural activities with the help of and the webinars with the Jenica platform. Our aim is to have our own website and the Instagram page if permitted. So we dare, we care. That's all about the SAPC branch. Over to you, sir. Thank you.
Hello.
Yes.
Yeah, should I moderate? Should I start the session?
Over to Dr. Bhavesh for further moderation. Yeah.
And actually, we welcome Dr. Manisha Katikar, Madam. Also, I think Madam just forgot for being the GC of National GC.
It's okay.
I request now Balaji sir to please share the CV so that I can share his introduction. Dr. Balaji Asegaonkar, sir, is a consultant anesthesiologist and palliative care physician at Aurangabad. Sir is a director at Ozone Anesthesia Group, ex-associate professor, MGM Medical College, Aurangabad, ex-honorary secretary, Maharashtra State Chapter, Indian Society of Anesthesiologists. Sir is president-elect, Maharashtra State Chapter, Indian Society of Anesthesiologists. Present affiliation, Director Ozone Anesthesia Group, Aurangabad, and consultant anesthesiologist at Kamal Nayan Bajaj Hospital, Care Sigma Hospital, and State Nandalal Dhut Hospital, Aurangabad. President of Sneha Saulis Care Center, Geriatric and Palliative Care Center. Sir has publications and presentations. Sir has published 15 research papers in national, international index journals, delivered 101 talks in conferences CME, delivered 49 online lectures on various topics in anesthesia, palliative care, geriatric medicine, and motivational talks. Sir has authored handbook Practical Approach to ABG Analysis, conducted 12 workshops on ABG hemodynamics, echo courses in geriatric medicines and palliative care medicine. Awards and honors: National Level Proficiency Award by ISA twice, Diligent Award by ISA 2022, and Appreciation Award by Geriatric Society of India. Welcome, sir. I request you to start your presentation. Thank you.
Greetings
Just
from...
before you start, sir, a request to mute all audio, except all the audiences except the speakers, and the questions will be asked either in the chat box or you can unmute yourself at the end and ask the questions to the speakers. Thank you, sir.
Okay. Should I start?
Yes, sir. Please.
A very good evening to all of you, and greetings from state. As a president of Maharashtra State Chapter, as you said, this is the first activity of Society of Anesthesiologists Pimpri-Chinchwad. Similarly, this is my first activity as a president of Maharashtra State Chapter. Yeah. And I'm really fortunate that you have invited me. Special thank to President Shobha Vatkar Madam, Bhavesh Seth Sir, GC Maya Bhalerao. And I'm very happy to see our Manisha Katikar Madam, National GC, my friend and Secretary Dr. Rajesh Tagadpalle, President-elect Anita Nehte Madam, and all my dear friends. Today I am going to talk about extrapolating knowledge of cardiac anesthesia for non-cardiac surgery. Now, greeting from Ozone Anesthesia Group also. We are doing Ozone Anesthesia Group practice at Aurangabad. And we have more than 32 consultants at Ozone. And before I start, let me tell you, we also have Ozone Learning Academy. And every Wednesday, we keep one talk at 8 a.m. in the morning. And all those practically oriented talks available on YouTube. If you want, you can watch them or want to listen them. They are available free online. Now, what is this extrapolation, this word extrapolation? You all know this cricketer, and nowadays he is in a special form. Yesterday only he has hit 1 century. And he's such a wonderful cricketer. He has got records in Test, One Day as well as T20. Now, how he is doing it? He is extrapolating his knowledge of cricket to all formats of the game. So, estimating an unknown based on extension of known knowledge or fact, that is what extrapolation is. When you work in cardiac anesthesia, when you extrapolate the knowledge of cardiac anesthesia for non-cardiac surgery, that is what I am going to talk today. So my aim of presentation is, whoever is listening, to convince everyone to learn that importance of working in cardiac anesthesia, at least for few days, few months, few years. Everyone must work in cardiac anesthesia so that you will be more proficient, or you will be more useful, or you will more confidently handle the other non-cardiac cases. Now, Madam was talking to me regarding sharing knowledge of cardiac anesthesia for non-cardiac surgery. But I thought an ounce of practice is better than tons of theory. So whatever the cases which I have faced, and I have applied the knowledge of cardiac anesthesia directly for the non-cardiac surgery, I tried to present before you the few cases which I have actually done. So let me start with first case. This is a 60-year female, known case of hypertension, diabetes since 20 years, and posted for lap cholecystectomy. She was having a severe osteoarthritis and bilateral edema fit was there. Lab was almost within normal limit. Echo was, when I saw the echo of the patient, echo was also normal. But when I saw the ECG of the patient, ECG was like this. Means there was clear-cut infarction was obvious in anteroseptal leads. There was no R wave present in V1 to V6. And there was still ST elevation was obvious on V2 to V3. I thought this ECG and echo finding is not correlating because such kind of ECG is invariably patient will have a poor LV function. And so as a surgeon I was habituated anesthetist for that surgeon, and he was a very strong belief in me. I suggested him to postpone this case and rather repeat the echo of this patient. And when we done the echo done, there was anterior dyskinesia, septolateral akinesia, and ejection fraction was 30%. There was some mistake due to the similar names, and echo report got mixed, and that normal echo report was with the patient. And so the conclusion is one must, even if echo report is normal, still if ECG is there, X-ray is there, you have to see the patient reports completely so that you can give some conclusion. By the way, when there is a dyskinesia, when normokinesia means heart muscle is contracting as usual normal. Hypokinesia means less contraction. Akinesia means no contraction at all. And dyskinesia means at the time of contraction, it is bulging out. And this bulging out was present in the ECG, what we call as aneurysm of LV. This is non-chronic ST elevation. When present in a ECG, it invariably indicates there is a chances of dyskinesia. This is very important. Now, all of us think that what ECG shows to us, rate, rhythm, arrhythmia, chamber enlargement, and electrolyte. These are the very common things. But ECG can tell us so many other things. It can tell us about volume overload. It can tell us about pressure overload. It can tell us about roughly ejection fraction. At least it is not a poor LV or normal LV. That prediction you can get with the ECG. It can tell about the presence of pulmonary hypertension. It can tell about LV aneurysm. It can even tell about which coronary is probably blocked. Even though such a sensitive investigation ECG's only limitation is ECG may be normal in dynamic conditions. When patient's heart, when subjected to a demand, at that time, if there are coronary block is there, that may not shown in the ECG. But most of the time, so every anesthetist must be well versed in reading the ECG. That is very, very important. As I talked about which coronary artery is blocked, I will not go in detail, but in which leads the changes are there. Is as per those leads, you can predict that which coronary is blocked. It is not 100% science, but most of the time you can, if you are the good connoisseur of reading ECG, you can tell all these things. And many cardiologists are doing this. They just see the ECG and predict that this patient will have such and such kind of block. And most of the time it is right. So ECG is very, very important. And as an anesthesiologist, we must learn ECG very thoroughly. Now, second is again a very interesting case. 30-year male operated for multiple perforations in abdomen, and surgery lasted almost for 5 hours. Patient received 4 liters of fluids, including blood. Patient extubated and shifted to ICU with heart rate of 110, BP of 100 by 50. And I got a call at midnight that patient will need intubation as patient's BP is not recordable and patient is very, very restless. And there are no palpable peripheral pulse. When I went there to intubate the patient was on noradrenaline 20 ml per hour through the patient was on noradrenaline infusion. I just, patient was oriented, restless with sweating. I just, as a clinical examination, put a hand on his femoral artery. And to my very surprise, it was very much bounding. It is not like that patient is having hypotension. And this was occurred due to, there was a peripheral circulatory collapse due to the excess dose of noradrenaline. Instead of intubation, we put a femoral arterial line to the patient, and patient's BP was 220 by 140 millimeters. As patient was in OT force, there was a peripheral vasoconstriction. BP was not recordable, or BP was on lower side due to this vasoconstriction. And naturally, intensivists go on increasing the noradrenaline, which again aggravate the situation. So instead of doing intubation to this patient, we just tapered off noradrenaline. We started NTG. As soon as NTG started, maybe in half an hour, his pulse plethysmograph starts showing on pulse ox, and ultimately patient settled over a period of time. So clinical, there is no shortcut to clinical examination. So as an anesthesiologist, you must clinically examine central pulse. This is very, very important take-home message. Now, third is again a very interesting case, 55-year female, obese, hypertensive, diabetic since 5 years, posted for laparoscopic hysterectomy. Patient, when asked about the history of effort tolerance, patient was having a poor effort tolerance. All lab and reports were normal. Echo was also normal with normal ejection fraction, and there was just comment on the presence of diastolic dysfunction. But when I clinically saw this patient was having a bilateral edema fit, basal crepes. Her heart rate were 100, BP was 160, 100, and saturation was 92 on room air. A person having a 92 saturation on room air, there is something abnormal. So I advised to patient to have a chest X-ray. When we saw the chest X-ray, there was a huge basal congestion. And why this was happening? Because patient was in diastolic heart failure. Diastolic heart failure, where the ejection fraction is reported to be normal, but patient was having a diastolic heart failure, and that is why patient was having all signs of failure, even though his ejection fraction, and this is a very known entity of heart failure, preserved diastolic heart failure with preserved ejection fraction, left ventricular ejection fraction. This is a very known one. And surgery, of course, postponed, patient put on diuretics, beta blocker. And once patient get optimized with diuretics and beta blocker, surgery done absolutely uneventfully next week. So clinically, one must see the baseline saturation. As the anesthesiologist, most of the time we see pulse, blood pressure, but looking the baseline saturation of the patient is very, very important. And thanks to Corona, or thanks to that COVID, that now pulse ox is ubiquitous. It is easily available, even in wards, even in at least small pulse oximeter is very easily available. So always make it a habit to see the baseline saturation of the patient, and it gives a very, very important. As far as diastolic heart failure is, systolic heart failure is a pump failure. I think someone's mic is on. Somebody's mic is on. Continuously there is some sound. And it occurs in aortic stenosis, hypertension, or severe mitral regurgitation. And diastolic heart failure, heart cannot be filled. Heart is non-compliant. There is a development of back pressure, which is leading to pulmonary edema type of picture, bilateral crypts, patient ascites in severe cases, edema fit. All these features are present in diastolic heart failure. So one, as an anesthesiologist, and it's pretty common, diastolic heart failure is not very a rare thing. So as an anesthesiologist, one must very carefully see, particularly in obese patients, hypertensive patients, valvular heart disease cases, IHD cases, look for specifically for a diastolic heart function, and that is very, very important. I will not go in details of diastolic heart failure, but there is just difference between diastolic dysfunction and diastolic heart failure. Invariably in diastolic dysfunction, patient will have reduced effort tolerance, and the patient always say dyspnea grade 3, grade 4, grade 3 type of dyspnea is present. And there is a frank signs of failure present with preserved left ventricular ejection fraction. We usually call it as a diastolic heart failure. And treatment is very simple. Just give diuretics, control his heart rate, and invariably this entity will be covered. Now, there are two cases, they are more or less similar. One is 40-year male, no comorbidity, posted for a lab cholecystectomy. Patient is giving a history of intermittent palpitation. His heart rate was 80, but it was regularly irregular. Other vitals within normal limit. Echo was not done. Another patient was 45-year male, smoker 20 years, posted for again lap cholecystectomy. Again, he is giving a history of intermittent palpitation. But his heart rate was more or less same, but irregularly irregular. Other vitals are within normal rate. Again, in this patient's echo was not done. When I saw the ECG of this patient, first patient, if you see, there was intermittent ectopics present in this. And in second case, also there were intermittent ectopic. But what is the difference? It is a monomorphic type of ventricular ectopic. Same kind of ectopic are appearing after certain beats. But here you see shape of ectopics is changing with the beats. It is occurring in salvos in multiple times with the same during the same contraction. So what is the conclusion? Conclusion is I just told patient to take a brisk walk for 6 minutes to the case A. Ectopic disappear. And these are the monofocal ectopic. This can be a normal phenomenon. So many patients have a monofocal ectopic. So you can do surgery very easily in this patient. But if you say same to this type big second patient to walk for 6 minutes, ectopics increased. Means these are the multifocal ectopics. These are the dangerous ectopic, and this patient needs further cardiac evaluation. But if patient can walk, and if you are palpating the, if you are feeling the ectopic, just tell them to take a brisk walk. This is a very useful clinical test, and it many times can solve the problem. So learning this is very, very important. When you know this, you can deal with the ectopics very confidently. Now, when to treat ectopic? These questions we are facing since our MD days. When they are multifocal, they are multiple, they are associated with hemodynamic changes. When patient is symptomatic with the ectopics, they are occurring multiple, means salvos, or there are occurs near the R-on-T phenomena. When ventricular contraction is going on, at the same time ectopic occurs, there can be, it can elicit the ventricular tachycardia. So those ectopics are dangerous ectopic, and that needs to be treated immediately. Now another case, this 30-year female posted for emergency LSCS. Patient is saying that she has an intermittent palpitation and giddiness. Patient was giving history. There was no other comorbidity, only 30-year-old female. Lab was absolutely within normal limit. Echo was not done. It is emergency seizure. But when ECG is seen, what was present on ECG? There was a P interval, very short PR interval with a delta wave. And what it suggests? It suggests that presence of accessory pathway or WPW syndrome, Wolff-Parkinson-White syndrome. What it indicates means there is some accessory pathway present in the heart, which is causing beat, sinus beat is going through this pathway, which can elicit supraventricular kind of tachycardia. With this ECG, only with ECG, you can conclude this. And when we took this patient, we keep defibrillator arranged inside the OT. And after pitocin, patient was suffered with symptomatic SVT episode. And the simple treatment is give cardioversion done immediately. This is a very simple steps, but this can you only done, it can only be executed when you suspect these things beforehand or before surgery. So clinical evaluation is very, very important when you are evaluating any patients for anesthesia. Again, then more or less two similar cases. One is lap hysterectomy. Both patients were posted for lap hysterectomy. This 52-year-old female diabetic, 7 years, IHD, post-MI. Ejection fraction was around 35% on echo. When I saw the detailed echo, there was anterolateral hypokinesia. And in another 54-year female, diabetes, IHD, post-MI, ejection fraction was around 40% on echo, and infero-posterior hypokinesia. Is there significance with this hypo kind of wall involved, left ventricular wall involved? Yes, of course. Whenever there is anterolateral hypokinesia, most of the LV part is at jeopardy, or it is not taking part in the active contraction of the heart. These patients are likely go into the failure perioperatively. They are intolerant to the fluids. This is very, very important. On the contrary, if there is infero-posterior kind of hypokinesia, they may be tolerant to the fluid. Again, this depends on how is the patient's status. Ejection fraction is one has to clinically evaluate the patient. But in general, I am talking, this patient may be tolerant to fluid, and perioperative arrhythmias kind of things are more common. This is not 100%, but if you are good clinician, at least you must remember these things, and you must see echo report in detail when you are dealing with such kind of cases. That is very, very important. So detailed echocardiography report must be seen in the context of the patient. Then and then only you will have a good suspicions, good degree of suspicion. Now, case 9, I got a call. I was just started at practice at that time. It is almost 15 or 17 years back. Surgeon was my very good friend, and the procedure was simple. C&D means just cleaning and debridement of the wound. And the patient was 24-year male, incised wound over the neck. There was small trickling of blood occurring since 5 hours. When I first went to see the patient, his half towel was almost soaked in the blood, and patient was sitting at that time and holding towel around his neck. And at present, not very massive bleeding. Small trickle was coming from that wound. Hemoglobin was 10 gram%. But when I saw this patient, I advised that surgeon not to do this case at his setup. It was a very primitive kind of setup. And he said, no, it's very simple case. I will just give local and 3-4 stitches, maybe small minor bleeder will be there. I will just cauterize it and we will shift the patient. But I advise him, don't do this case. This is a potentially dangerous case. Why? Because this incise wound was here. And these all major vessels travel through this area. And maybe due to pressure or maybe due to anything, that was probably concealed or bleeding was minimal at that time. So advanced surgeon listened to me, and we refer this case to a government medical college. And after 2 hours, I got a phone call from surgeon that you saved me. That one of the resident tried to open this case. He put a retractor, and patient suddenly bleed massively and died on the table. So as an anesthesiologist, if you know the anatomy, if you know all these things, and if you have a good degree of suspicious what can happen, it can save you many times in the private practice. Now, 58-year diabetic patient since 20 years admitted in surgical unit, pain in abdomen and vomiting, and posted for a gastroscopy. Simple, very simple procedure. Incidentally, there was a ERCP call, and I was there, and that patient, surgeon gastroenterologist said, I will just finish gastroscopy and we will took the ERCP after that gastroscopy. I was just waiting there. Incidentally, I saw the ECG of that patient. When I saw the ECG, there are massive STT changes. STT changes in almost all leads. What it indicates, a patient who has got a pain in abdomen, vomiting, diabetes since 20 years, posted for gastroscopy, and with this ECG, this can be a myocardial infarction. Not only that, this can be a patient with a severe form of coronary artery. This is like left main blockage. I advise him not to do this case only. He we decided, as I explained him, this can be a cardiac. So he immediately shifted this patient to a cardiologist, and cardiologist, when saw the ECG, he immediately posted that patient for coronary angiography. And what was picture in coronary angiography? There was a left main block. And unfortunately, that patient arrested after a first shoot in cath lab because left main artery is completely blocked. And that is why patient was having such a severe STT changes. So more than 8 to 10 leads STT changes is a very, very dangerous thing. And one must look ECG carefully for that. Now, the last case I'm going to tell, this is a 67-year male hypertensive patient posted for TURP. All lab, ECG, echo within normal limit. Case started in spinal anesthesia. Till end, there was no episode of hypotension and a case went absolutely uneventful. And suddenly, patient arrested on table. Immediately CPR started, but patient was not responding. As cardiac OT was just beside that Euro OT, they asked for help. When we went there, we called echo machine and just as Desurkar sir knows, we do initial just echo assessment of that patient. And what we found a massive air in the patient's heart, massive air embolism. As we know the cause, we vigorously started giving CPR to this patient, and patient successfully reverted. By that time, once patient reverted, blame game start. Junior was managing case. We thought that he has injected incidentally air into the IV system, and we were discussing all that. And suddenly, surgeon told us that there was a crack in this bottle, and while taking out that pieces, he accidentally injected all air into the patient's venous open sinusoids, which are just dissected during the TURP, which leads to this massive air embolism. But due to this immediate echo, just putting echo probe on patient's heart, we could survive. We have given almost given CPR for more than 40 minutes to this patient, and patient went home because we know the reason. We know this can be the cause that can be treated very well. So we aggressively go with this, and this is only possible because we could put echo probe on the patient's heart immediately in that situation. So the take-home message is knowledge of cardiac anesthesia always helps immensely to manage cardiac patient for non-cardiac surgery. Cardiac anesthesia makes you more versatile anesthesiologist, and everyone must work in cardiac anesthesia or even in anesthesia with aim to develop that common sense of anesthesiologist to avoid the complication, to deal with the complicated patient. And common sense is the knack of seeing the things as they are and doing the things as they are ought to be done. And this sense, definitely, I think if you work in cardiac anesthesia, it develops better, it grooms better. Thank you very much.
Thank you, sir. It was a very practical approach, and you have really elaborated all the practical cases, I believe. Can we take the question answer in the end, or should we go ahead with the madam?
In the end, we can.
Okay. So now I would like to invite our second speaker, Dr. Anita Nethe, madam. Madam, please can you share your slides?
Yes.
Yeah. So Dr. Anita Nethe, consultant anesthesiologist from Pune University. Important post held by Madam President-elect MSc ISA, Vice President MSc ISA, Editor MISA News, GC member of MSc ISA, and President ISA Nashik. Awards in her credit: President's Appreciation Award at State and ISA Proficiency Award at national level. At present, consultant anesthesiologist at Vedant Hospital, Nashik. Achievements invited as a faculty in various state and national conferences, charitable activities, working with Smile Train as anesthesiologist, active Rotarian since 2016, and certified trainer IRC and PPLS. Welcome, madam. Please start sharing your talk.
Thank you, Dr. Bhavesh, for that kind introduction. Am I audible?
Yes, madam. Very much.
Yeah. So a very good evening to you all. And thank you, SAPC, Dr. Bhavesh, Dr. Shobha madam, and Dr. Maya madam for giving me this opportunity. And today I am also discussing only case-based. So this is very practical. I really liked Dr. Balaji's tips about non-cardiac anesthesia. Really, we are so afraid as a non-cardiac anesthetists that whatever will happen to this heart. So if we work in a cardiac setup, I think we can really do justice to our patients. So today I'm going to talk on anesthesia for acute as well as the burn contracture patients. And the actually incidence of burns injury in India is very high, and it almost 10 to 70 lakhs cases happen in a year. And this high incidence is because of our illiteracy, poverty, lack of safety measures. But it is heartening to know that majority of these burns injuries are preventable. And this initial care of the burn injured patients, it presents really some unique challenges like airway management, vascular access, hemodynamic management, and respiratory support. And all this can be done very well by an anesthesiologist. Anesthesiologist is the best person to manage all these problems. So let us So let us go to a case directly. And this is, as you can see, this is a child, 2-year-old child, weighing 10 kgs, has 30% burns of face and arms. And he has a history of house fire. The child was entrapped in the room. The child is drowsy, irritable, but the saturation is good. It is 98%. The pulse is 170 and the blood pressure is 70/35. So the picture somehow is not fitting. And the child looks actually quite sick to you. And there is soot around his nostrils. There is his intranasal hair are burnt. There is a huge swelling of the face and tongue. The child's breathing is not looking good. Capillary refill is prolonged. Now this child is posted for debridement in a nursing home. So what will you do? And how will you induce this patient? And what is all these things indicating to you? What is your differential? So actually this child is looking very sick, and do you think you can induce this patient? Though we are on webinar now, if we had been in front of each other, I would have really liked to see opinions of people. But because we are online, I would start sharing my further slides. So actually what this child is having is some sort of airway injury, and a smoke inhalation injury or injury to airways can occur because of many types. First type of injury is a thermal injury, because maybe the child has directly inhaled the hot flames, and that hot gases inhalation can lead to very bad severe upper airway injury, and this will lead to picture like this: inspiratory stridor, a very bad airway swelling. And this thermal injury to airways warrants urgent intubation. And definitely you cannot tackle such injury in a nursing home setup. The second type of injury that can occur is because of a chemical injury to the lower respiratory tract. The first direct injury that we saw, that was to the upper airways. Now this is because of chemical gases, toxic gases like hydrogen chloride, phosgene. The chemical gases destroying the lung epithelium, bronchial epithelium. So directly the lung is getting sloughed because of this chemical toxicity. And again, this requires supportive respiratory care, intubation. This actually requires a lung protective ventilation and lung toilet, aggressive pulmonary toilet. You need to suck out all that debris for the child to survive. And the third is a carbon monoxide poisoning. So in closed spaces, we see that carbon monoxide it has actually a very high affinity towards the hemoglobin. And when carbon monoxide poisoning occurs, the oxygen dissociation curve shifts to left. Though the oxygen is there in the body, it cannot be utilized. There is severe hypoxemia. So all these symptoms were the irritability, the drowsiness, were because of severe hypoxemia actually. And it is not easy to diagnose because your pulse oximeter cannot differentiate between carboxyhemoglobin and your oxyhemoglobin. So it will keep showing your normal saturation reading. And even the arterial blood gas will show you normal PO2. So the co-oximeter can tell you that it is, but I am sure co-oximetry is not available everywhere. And the blood levels of carboxyhemoglobin can tell you this. So the diagnosis has to be clinical. And severe picture of hypoxemia, picture nausea, vomiting, headache, hypotension, convulsions, drowsiness, coma. So this tells you that it could be, you must suspect carbon monoxide poisoning. And the treatment is simple. It's just 100% oxygen. So the moment the child is taken out from that entrapped room, the carbon monoxide is getting excreted. But if you give 100% oxygen, then the half-life of this carbon monoxide it reduces very fast. And in 1 hour, you can get half of the CO2 almost removed from the body. So 100% oxygen, how you can give? Because of COVID, we have an advantage. We are having now this non-rebreather mask everywhere. So what this child needs actually is 100% oxygen. Now you assess the airway. You see whether the volume resuscitation is done properly, adequately or not. And this child needs a good peripheral or a central line. Immediately after the oxygen is put, in few minutes or in 1 hour time, you will come to know whether there is improvement in mentation or not. And then you have to assess the airway to see whether his child is going to need early intubation and ventilation in a pediatric ICU. So if you should not definitely touch this patient in a nursing home setup, because if you give any sedative to this patient, this child, you will lose airway and the child can arrest because the hypoxemia will increase, and then you will not be able to save this child. So it is very important to recognize a smoke inhalation injury in any patient, in an acute burns patient. Now coming to the second case. Now this is again a child with a face burns, but it is facial scars, and the burn injury, only 15% scars are there. The child is posted for collagen application. The vitals are stable, investigations are normal. So what anesthesia will you give? Now, do you want to intubate this child, or you can avoid intubation? Can you just do this on a short GA, what we call, or a TIVA mixture? So the answer is yes, because the child has no other injuries and the child's airway looks good. Only thing, you need to take care that the child's airway is maintained very well. So you need to give good extension to this child, and you can very well do this case under only a ketofol. Ketofol is a 1:1 mixture of ketamine and propofol, and it's a very extremely popular mixture, especially for burns dressing. And it gives excellent analgesia to this burns patient. The ketamine as well as propofol, they actually compensate for each other's side effects. So I very frequently use ketofol for a burns dressings patients. Another TIVA mixture that you can use is the ketamine propofol dexmedetomidine mixture. You can mix these in one syringe itself. What you can do for this child is take 25 milligrams of propofol and add 25 milligrams of ketamine in that. So it becomes total 50 milligrams, and then dilute it up to 5. So now you have a mixture which has a 10 milligrams per cc of ketofol, and then you can use this 2 milligrams per kg. So very useful Tiva mixtures. Now let us go to the next case. Now this is again an acute burns, a 55-year-old lady weighing 60 kgs. She has 50% burns, and the burns has happened 6 hours ago. The patient is conscious. Pulse and BP are okay. Now she has received around 2 liters of Ringer's lactate via a peripheral line. And her airway is okay, Malampatti grade 2, and no other comorbidity she has. Now she is posted for dressing under anesthesia. So how will you manage this patient? Now, will you give ketofol to this patient? What do you think? Do you think she is adequately volume resuscitated? Now, if you actually calculate her, you must see whether volume resuscitation is adequate or not. And if you see Parkland formula, it is 4 ml per kg per percent of burns. And this much fluid you need to give over 24 hours. So coming back to the case, her dose comes to 60 multiplied by 50 multiplied by 4. So it comes to almost 12 liters. Out of this 12 liters, you should give half, that is 6 liters in first 8 hours. Now 6 hours have passed. So in 2 hours, it will be 8 hours and she has received only 2 liters. So if you see, if you take this into consideration, she actually is short by 4 liters. So if you give any induction agent to this patient, she can have a drastic fall in blood pressure and even she can arrest. So it is not advisable to give in this acute setting before resuscitation. This patient needs first a good volume resuscitation, oxygenation, a central line, urine output monitoring. She needs analgesics, antibiotics, and the first priority is not to do a dressing under anesthesia, or you can do dressing without anesthesia because many of times they have deep burns and they are not painful. So you can just cover the wounds, and first priority is to stabilize the patient rather than to give anesthesia to this patient. So let us see what is the pathophysiology. What happens in acute burns? There are 3 distinct phases. And in the early or burn shock phase, which lasts for around 1 day or 24 hours, there is a huge amount of release of mediators of inflammation. And the capillary permeability is increased so much that the fluid is leaking from all over the intravascular space and leaking into the interstitial space. So this leads to a massive edema formation. There is huge interstitial edema and nothing is there in the intravascular compartment. So there is a severe hypovolemia combined with the interstitial edema. So how the blood pressure is maintained? Why the blood pressure was not low if the patient is hypovolemic? This is because there is severe increase in sympathetic stimulation because of pain and simply because of the stimulation of the fire, the flames. So though the patient is hypovolemic, the patient has severe reduction in cardiac output, the blood pressure is maintained. But moment you give any, even ketamine to this patient will drop blood pressure precipitously. And there is so much hemo concentration in these patients. If you try to draw blood from peripheral vessels from these patients who are burnt more than 50%, then you will just get a thick, tarry, black fluid and not your red blood. So much hemo concentration has occurred in this patient. So very fast you need volume resuscitation in these patients. And your first priority is volume resuscitation. It will lead to reduction in the burns depth. It will lead to improvement in the patient's other organ functions. And then the next is the phase of diuresis. So if you happen to find the patient in this phase, where the capillary seal has now re-established, and in this phase you can have a lot of diuresis the patient is having because you have infused a huge amount of fluid, so that is now coming out. And this can lead to electrolyte imbalance. If there can be severe hypokalemia, so this can happen in this phase of diuresis. And in the late hypermetabolic phase, you will have massive catecholamine surges, and the patient will have systemic hypertension. You might require treatment for the hypertension because of increase in metabolism, basically hypermetabolic phase of burns. So this lasts for almost up to 9 months. So it is important that to know that how much time has passed since the burn injury when you are seeing this patient. Now coming to this next case. Now she is a again 40-year-old female with a deep circumferential burns on chest 2 days ago. The patient is volume resuscitated well, and now because she has circumferential burns on chest, she cannot breathe and she needs chest wall ischorotomy. So what anesthesia will you give? So will you again give her ketofol? What do you think? Now these patients are having so much deep burns, are very moribund patients, and they are really sick patients. So, and also the burns is so deep that a patient is not feeling pain anyway. So mind you, you don't need to give any anesthesia to this patient, and the surgeon can just with cautery or even with scalpel can just do the ischorotomy without giving any anesthesia, because the patient has got burns still bone deep, and these burns are not painful. So you don't need any sort of anesthesia for this patient, thus ischorotomy patients. Now, coming to this patient, yes, so this is our standard post-burn contracture case, a 45-year-old female weighing 80 kgs. All her investigations are normal and she has no comorbidities, and she has got burnt 5 months ago. She has extensive neck contracture, and when you see her Malampatti is grade 4, so you can only see a hard palate when she opens her mouth, and she almost, there is no neck extension. In fact, there is some neck flexion because of the contracture. So her maxilopharyngeal angle is slightly less than 90. So what is your preference now? How will you induce this patient? And what is your plan for airway management? Let us see one by one. Now, whenever you have a predicted difficult intubation like this, it is very important. Certain things you must do. You must pre-oxygenate the patient for full 5 minutes so that you get good amount of time for your manipulations, airway manipulations. So pre-oxygenation absolutely important for 5 full minutes. And whether you are doing an awake, you have only 2 options: either do a awake or a spontaneous. You must keep patient on spontaneous respiration. So if you want to induce the patient is a child or patient is uncooperative, then your options for inductions are very limited, and that is sevoflurane or a combination of sevoflurane, propofol, and ketamine. Because if you induce with sevoflurane with an intention to maintain spontaneous respiration, but moment you remove the mask from the patient's face, the patient's depth of anesthesia is fast going to reduce, and if you are struggling with your scope, the patient is going to cough. So you need to maintain this depth with other intravenous agents. Now scoline, you can't give scoline to this patient because just 5 months have passed since burns, and otherwise she will have that hyperkalemic response. So what is your plan? Whatever is your plan for intubation, it has to be detailed discussed with your assistants in the OT, assistants who are non-anesthetist assistants, and even your anesthesia assistants. Everybody has to be aware that what is your plan A, plan B, plan C. And needless to say that your difficult airway cart has to be there with all size airways, oral airways, nasal airways, all size tubes, the video laryngoscopes, the eye gels, the various LMAs have to be ready. And the surgeon has to be ready for the surgical release of the contracture. So what is your plan A? Plan A can be a awake fiber optic intubation, but there are challenges in this. Even if you are, the fiber optic bronchoscope has to be available at your place, first thing. And even if it is available, it is very difficult to put in fiber optic scope in a very fixed flexion deformity patient, and it is difficult to thread the tube over the scope, even if you have successfully done the fiber optic bronchoscopy. So you really need a special expertise to be able to pass an awake fiber optic in these patients who are extremely having a very bad neck contracture. So this railroading of the tube over the fiber optic may be sometimes extremely difficult. And if you fail in your first attempt of this fiber optic, then the patient is not very cooperative. I mean, you can't go on poking for minutes and hours, and the patient, there can be bleeding inside, there can be edema inside. So you have to stop at some point. And then your plan B can be, or if you don't have fiber optic at all in the first place, your plan A itself can be induction on spontaneous respiration with the help of maybe sevoflurane or a combination of sevoflurane propofol, and followed by a checked video laryngoscopy. So when you do this check video laryngoscopy, what do you see? You see whether you can see the epiglottis, whether you can see either the posterior commissure. And if you see posterior commissure, you can just thread a bougie, and or you can directly put a steelet, make it J-shaped, and thread an endotracheal tube into the cords. So it is possible that with some anterior manipulation in some patients you can do, and with video laryngoscopy you can get away, and with this your plan B. Now if your plan B also fails and you can't see anything on your video laryngoscopy, then what else you have? I mean, what is your next plan? So there is nothing else you can do, but you have to go for a surgical release of the contracture under local anesthetic, and combination of your ketamine propofol and local anesthetic, and release the contracture, and then put a tube under the direct vision. So now here also challenges are, while the surgeon is reducing your, and that is why the surgeon has to be ready in the OT. Surgeon has to be scrubbed. The neck contracture area has to be painted and draped, and everything standby, everybody ready while you are doing your plan A itself. If that is not successful, then your plan C, the surgeon has to be ready with scalpel in his hand. So while the surgeon is releasing this contracture itself, you have to maintain the oxygenation and depth of anesthesia. That is also challenging. Now, while the surgeon is releasing the contracture, though you can lose airway and the patient can start desaturating. So your plan D, you have to be ready with any laryngeal mask airway like iGel or ProSeal, and you put that in, and it's only for a rescue ventilation, only to ventilate and take the patient out. You use laryngeal mask airway. Otherwise, the gold standard for airway management in contractures is always an endotracheal tube. People have maybe done cases on laryngeal mask airway, but the gold standard is always endotracheal tube, because there is so much movement of the head occurring when the surgeon is releasing the contracture, and when they release the endotracheal tube itself comes out almost 2 centimeters out. So much distance the tube moves when the head is flexed, and when the head is extended, the tube comes out almost by 2 centimeters. So your endotracheal tube, once it is in, it has to be stitched to the oral commissure, because with the drag of the circuit, the tube can come out intraoperatively, and then that will be disastrous if it is inadequately released contracture and the tube comes out in between. So the tube has to be stitched, the circuit has to be fixed. And all this, at the end of the surgery, what happens? Again, at the end of surgery, the patient is in full neck extension position. So you have to tell the patient beforehand that when you come out, when you wake up, your neck will be extended like this. And again, there you have to, while extubating, whether to extubate awake or whether to extubate deep, that is controversial, because if you try to extubate this patient awake, the patient will cough so much, and then the whole graft will move, and the surgeon will not like that at all, because when the patient is coughing, this whole area will move. So nowadays we have Sugammadex, and that is a wonder drug. So you give, and within 1 to 2 minutes you can remove the tube. The patient is totally out with good power in his pharyngeal muscles. And with Sugammadex, really we are very happy to use in such type of patients who are obese, who are having all these airway problems. So this was plan A, B, C, D for airway management in this neck contracture case. Now this is another, let us see another case of neck contracture. She is a young 23-year-old female and she has got burns in her childhood. So burns 17 years ago. And now she has, the contracture is not much, but but she has severe hypognathia, as you can see in the picture. The mouth opening is good, but her Malampatti class grade is almost grade 4. You can see only heart panic. So now what is your plan for intubation in this patient? Maybe the contracture is not very severe, but the Malampatti is grade 4. Now in this patient, advantage is she is very thin and you can use choline in her because the burns history is many years ago. So you can easily use choline. So this plan can work, that you pre-oxygenate well, give her propofol, keep on spontaneous, and you check whether the patient can be ventilated well and do a direct laryngoscopy. Now, if on doing direct laryngoscopy, if you can see larynx or if you can see epiglottis even, then you can remove the scope, give her choline and ventilate her well. And then again, do a direct laryngoscopy, pass a bougie. If you can see a posterior commissure, you pass a bougie inside, or blindly you can pass a bougie just behind the epiglottis, which you can see well. So that plan can work in this patient because she is thin and she can be ventilated. You can use choline in this patient. So these are different types of neck contracture patients in which, but basically the management plan A, plan B, plan C, plan D remains in that sequence only. So if you want in any particular patient, you want to use a awake fiber optic, then it has to be a plan A. Your plan A has to be awake fiber optic. If you don't have fiber optic, then your plan A has to be a video laryngoscope. Because you can't do awake fiber optic at the end when the patient is uncooperative, when there is blood in her mouth, blood in her throat, then you won't see anything in the fiber optic bronchoscope. So it has to be in that sequence. Now coming to this case, this was say a 20-year-old female, history of flame burns 2 months ago. Her mouth opening is very small and she has got severe microstomia. Her whole mouth has shrunken. Though her neck is okay. I mean, the neck extension is not very good. But she has a total very deep facial burns and she was a thin patient. So absolutely she had no fat on her face. And with these deep burns, all that has stuck to her bones and it is sort of got plastered. That scar has got just plastered to her bone. She's a young patient and she is not cooperating for awake fiber optic bronchoscopy. She's saying, no, you first give me anesthesia, then do whatever. So how can you proceed with this patient? Now your plan is you can induce with sevoflurane and again combine with propofol and just do direct laryngoscope and see. When you do that, you find that the Cormack Lehan is grade 4. That means you can't even see the epiglottis. See what happens in these patients, the tissues are so deformed and the epiglottis might be there in front of you, but you can't recognize it because it is become so fibrous or so stubby that unless you see that chink of larynx, you won't know, okay, whatever is anterior to this, it may be epiglottis. So the anatomy is so different. So this, you can't see anything and it is grade 4 Cormack Lehan. You can't see even epiglottis. So what do you do now? So again, according to the next plan, the surgical release of oral commissures will give you some space in the mouth and also the neck contracture, and then direct laryngoscopy and intubation can be done. So that's what we did with this patient. Now this patient had multiple surgeries and at the end of all the contracture release, she was looking like this. And she was not happy with her picture at all. So she wanted her face to be transformed. So we did multiple free flaps on her face and totally she underwent almost more than 15 major surgeries and more than 50 dressings under anesthesia and so many procedures. So I must have anesthetized her at least 100 times and over a period of 1.5 years. So after she finished with her treatment, she was looking like this. And we go to our next case. Now this is just I wanted you to be aware. So this is a case of 1-year-old child with a 30% burns, and after 1 week of dressings, the child is showing low saturation on SpO2 is showing 85%, but otherwise the child is good. Vitals are stable. The child is feeding, eating well, and so I mean, why the saturation is showing low? So you do a ABG, and the ABG is normal. So what is this? So this is actually the child is having methemoglobinemia, and this can happen because of the silver nitrate in the silver sulfadiazine ointment. So what does this silver nitrate do? We were also surprised. So we did literature search and we found that the silver nitrate can lead to methemoglobinemia. And this methemoglobin, even if small amount, 3 to 5% is there, it interferes with your SpO2 reading, and falsely it will show you a low SpO2 reading. And the treatment, you don't have to do anything, just discontinue the ointment. So that picture also can be there. So now I'll just in short summarize the challenges for anesthesiologists in burns patients. So whenever you see a patient with acute burns, you must rule out that whether the patient has any airway injury or smoke inhalational injury, how whether the patient has had adequately volume resuscitated or not, whether there is airway edema or a tight ishar. And altered pharmacokinetics of drugs is there in this patient. At all stages, there will be different problems. There will be monitoring difficulties. Sometimes all the patient's limbs, the fingers as well as the toes will be burnt, and you will not know where to put the pulse oximeter probe. So you can put put the pulse ox probe on the ear. Even the ECG leads, you won't know where to put. The vascular access will be difficult. The central lines will be coming out of the burnt wounds. And the sepsis is always looming large on this patient. So anytime during the course of their treatment, they can go into sepsis and can become more sick. In the patients with neck contractures, you must assess the difficult airway. And yes, in the altered pharmacology, in the initial phases, these patients are losing so much protein, so much serum they are losing in their dressings that they become, the albumin levels drop. And so because of low albumin, the more free drugs is available. So you need to give the drug slowly. You need to give a smaller dose. During the shock phase, again, you need to adjust your dose. The scoline and this, we have seen that upregulation of the acetylcholine receptors are there, so they can have life-threatening hyperkalemia if you give them scoline in this period. And also there's a resistance to non-deplorizing. So you need a higher dose of your non-deplorizing relaxants. And during the hyperdynamic phase, you need increased drug doses of all your drugs. I have specially included this pain management because superficial burns are extremely painful. And these patients have hyperalgesia, means more pain for the same amount of this, and allodynia, that is, even the touch becomes painful. So if you don't treat this pain, then they can land into chronic pain syndromes, and lifelong it will haunt the patient. So what pain modalities are available with us? We can give paracetamol and opioids for the baseline pain, for background pain. And morphine PCA pump is actually used in foreign countries, but in our places, morphine availability is a problem. Our patients are not used to PCA. So we tend to use a lot of tramadol and other drugs like NSAIDs. NSAIDs like diclofenac is very good after the initial shock phase has gone. So a combination of paracetamol, diclofenac, and for procedural pain, the addition of ketamine, and antipsychotics like nortriptyline and gabapentin. Combinations now are available like nortipan. They are very good as a part of multimodal analgesia. So if you give a good analgesia to this patient, you can really prevent the chronic pain syndromes, and that will really help these patients in their improving their quality of life. So to summarize, acute burns as well as post-burn contractures present unique challenges for the anesthesiologist. And anesthesiologist is an integral part of the multidisciplinary team managing burns. The anesthesia challenges in acute burns require careful assessment of adequacy of resuscitation, airway compromises, presence of smoke inhalation, and you must be aware of the altered pharmacokinetics of the drugs. Whenever you are faced with any difficult intubation, a predicted difficult intubation, a detailed plan has to be ready. Communication between your assistants, between your surgeon is extremely important. And as ultimately it is a teamwork, because you need to work in that close few minutes of time where you want to achieve the endotracheal intubation, successful intubation in this patient. So it is very important to work as a team, and really you must there has to be a meeting. You must talk, and everybody has to be on one plane when you are faced with such difficult post-burn contracture patients. Now you must consider how is your setup, whether you have adequate equipments necessary for this case, whether you have a good assistance. And like the equipments, like suppose you must have a video laryngoscope, it has to be there. You have to be trained in using that. What is your own skill set? Like suppose you have a fiber optic bronchoscope, but you are not very well versed in using that. So you will need somebody who is expert at using fiber optic scope. So you should consider whether this your skill set is adequate and for that particular case, and then only you should give such case. And a good pain relief is advisable with multimodal analgesia for a good quality of life of these patients after burns, because burns is, once it happens, it stays with the patient lifelong. The scars are there lifelong, and you can really play a very important role in these patients' life. So thank you for patient listening, and donate skin and save life. This is the logo of our skin bank. We at Vedant Hospital run a Rotary Vedant skin bank since 2016, wherein we take skin donations, just like eye donations, and that helps patients who are extensively burned. So thank you for patient listening.
Thank you, Madam Anita. It is so elaborative that it is not possible to have a best management in those burns patient in one go. I think so. We need to see this recording again and again. And your plans were so good. Like it is not the one plan we should think of while doing the all burn contracture patients. But we need to have at least multiple plans. If one doesn't succeed, you may have to go to further and further and further till you can intubate the patient. I think just like Dr. Balaji Asekavkar said, an ounce of knowledge is more than tons of theory. And we need to even work in the burns unit, I suppose. Like how we need to work in the cardiac anesthesia similarly. Thank you so much. Yeah.
Yeah, madam, very practical approach and lot many take-home messages, I believe. Now, I think we'll open the forum for question and answers. If anybody wants to ask the question, please raise the hand, or you can directly unmute and ask the questions, no problem. Yeah, there is one question: how to convince the patient and surgeon regarding airway importance for a patient with post-burn contracture? Dr. Bhageshri has asked. Definitely, it will be for Nete, madam.
Dr. Bhageshri, how to convince patient and surgeon regarding airway importance for a patient with post-burn contracture for surgery under spinal. So I think madam wants to ask that surgery is to be done under spinal anesthesia, and patient is having a PBC neck. So
actually, the surgery is, madam, abdominal hysterectomy.
Yes.
So we can definitely do it under spinal, we know. But any complication like high spinal or anything, hypotension, arrest, anything can happen. And patient is having post-burn contraction, severe. So surgeon thinks कि यार spinal के अंदर हो जाएगा. What is the need of all other things? And patient also doesn't have that importance. So
no, it is important to tell everything to the patient, and I mean you have to invest time in this, and you have to take written consents and tell the patient all the possibilities. I think the surgery gets prolonged and you need to convert it to GA, then it is better to start with the spinal approach right in the beginning. So
Yeah.
We can prolong with epidural, and high spinal, I think you can really avoid by, adjusting the dose.
No, adjust means for even for such cases, should we keep standby fiber optics or these, because small setups don't have all these things, and just keeping it for standby, owners are not comfortable.
Madam, on
Can
this
I add
point, I will tell you that you have to, and you have to tell the surgeon, the patient, yes, because if anything can go wrong, and the patient can arrest, and then you need to intubate just for, suppose the patient has the infarct and the patient arrests, and you need to do resuscitate this patient, or you want to intubate, then what to do? Totally unrelated to the surgery, but everything has to be.
Yes.
I think these cases should be done at the corporate level or the high-end centers, because anytime the spinal turned out to be a nightmare and may I have to resuscitate, as you said earlier. If anything goes wrong, we are in the suit always.
Yes. Suppose some anaphylaxis happens, something
Anaphylaxis.
related happens, and you need to resuscitate, for which you need to intubate the patient.
Can I add something, Anita madam?
Yes, please.
Yeah, madam.
Yeah. Bhageshwari madam, I feel that whatever may be the choice of anesthesia, whether regional, general, spinal, unless you have guarantee of securing the airway, you should not go for any kind of anesthesia. So even if you are giving spinal or even a peripheral nerve block, everything should be made available for intubating the patient if needed. As madam said correctly, if there is anaphylaxis, if there is any emergency scenario, we should not give that explanation key, because I'm practicing in periphery and I'm doing this case under spinal, which is the safest anesthesia here. So this should not be the option. That's what I felt. So if you are giving spinal, you have prepared for GA. If everything is made available, and if some legal issue occurs, you are safe. It is difficult to intubate a patient of neck contracture in an emergency. Yeah, that I think Shilpa, this madam has nicely explained everything. So,
No, it is similar that even if you give peripheral nerve blocks, we always keep the general anesthesia trolley ready. If it's like it may be a last, it may some anaphylactic reaction, or it may be intravascular. So happens. So similarly of that kind, I think intubation may be needed for any time, and that case should be done at the higher centers, I suppose.
yes, that is absolutely true. That it has to be done under higher center with all the facilities of difficult airway and difficult airway cart is available. That should be and a helping hand in an emergency also. That is also more important.
And we need lot of manpower during that time, maybe, which is lacking.
Another suggestion I would like to give is use of video laryngoscope. As an anesthesiologist, we should very commonly use video laryngoscope because it gives us a view of larynx through pharynx. We are getting 40% more visualization of larynx through pharynx. And if you are using deep blood, it is giving 60% more views of larynx. So if you use this video laryngoscope routinely, and nowadays it is maybe 3-4 people in combination can purchase it when practicing at periphery. And it's a very good tool to, at least you can see, just give propofol on spontaneous ventilation. Can this patient intubate you? You can intubate these patients.
Yes, video laryngoscope is definitely in your plan. I mean, is there, and it also has a learning curve. So you must definitely use them in at least 20 of your normal patients.
Yes.
And each video laryngoscope is different. I mean, if it is the air track type of video laryngoscope where you are putting your eye to this thing and channeled one, then you need to remain away from the larynx and then thread the tube.
Yes.
If it is the Macintosh type where your camera is right there inside, then you are normally intubating with Macintosh like that, but you see, instead of seeing inside, you see it on the camera. So every video laryngoscope is different. Even King Vision, but what I have found is King Vision, it is very difficult to introduce in a patient who has a flexed neck. Even a normal patient, it is difficult to introduce. So you need a good extension of plane of head. This head needs to be extended very well if you want to introduce King Vision into the patient's mouth. So it is out of question for a neck contracture patient. So scope will not go inside. It will touch the patient's chest. So the Macintosh blade type video laryngoscope can enter inside, yes, anytime. So there is one Medicam, that is the name of the scope. It is like, it's just like Macintosh laryngoscope, only you have a camera and you have a screen out. So that
Yes.
can use.
Yes, you rightly said it should be practiced in normal patient first.
Yes. And on that scope also, what you see is commonly is, you see somewhere the larynx is somewhere, so you do need external laryngeal manipulations, and though you keep seeing the larynx, the tube is not reaching there. So you need practice for that. You need a bougie, and how to thread, how the bougie should reach the larynx, that for that also you need practice.
Anita madam, one thing about Macintosh laryngoscope, because I am also using it more frequently. Awake intubation is really not that easy with Macintosh type of blade than the King Vision or any other thing. So that is the issue, like for a patient of one contracture or a patient of very difficult intubation or neck cases which I am doing restricted neck movements. So in such cases, awake intubation may not be possible with Macintosh type of laryngoscopy.
Neck contractures, you have to rely on the airway anesthesia with just nebulizations or gargling, because the neck is not accessible to your blocks. Means you can't really palpate the hyoid or anything. So you need to nebulize with 4% lidocaine, a good amount of nebulization, and even gargles. So if you do that, then sometimes the patient can tolerate even with your Macintosh. What happens with Macintosh type laryngoscopy, you are going so deep at the epiglottis, at the junction of epiglottis and anterior pharyngeal wall. So there you are poking, it's poking too deep inside. So the patient cannot tolerate that scopy. But King Vision is sliding over your tongue. So that is more tolerable. Yes.
Anita, can I ask, what is the tumescent anesthesia in this burns contracture? What is the tumescent?
Yes, tumescent anesthesia is nothing but a very dilute lignocaine. So 0.5% or maybe 0.25% lignocaine. You can take in 100 cc, 200 cc, whatever is your required infiltration. And adrenaline, which is 1 in 2 lakhs. So you adjust the dose. If you are taking 100 cc of solution and make it 0.5% lignocaine, so you adjust and put dose. So in 100 cc, if you want to make 1 in 2 lakhs, you can put, I think, half ampule adrenaline. So it will become 1 in 2 lakhs. So basically the tumescent anesthesia has lignocaine and adrenaline, and that you can inject in large amounts in the tissue, and then directly you can incise with very good local anesthetic, and maybe a small amount of sedation.
So can it be used, those two, I mean, if you simultaneously do the direct laryngoscopy from the top, and we use a tumescent anesthesia, and the surgical person will go on cutting that contracture. Like if there's 3 scars or some scar tissue in the anterior side of the neck, that the tumescent, will it help till the...
It helps, madam. Means we have done for some patients like that. Almost you had to cut till the trachea, because some of them are so badly contracted, and that time we did not have video laryngoscopes. These are around 10-15-year-old cases, because
that might be the age-old technique, isn't it?
Nowadays you don't see this very bad contractures, because patients come early for treatment. But previously, so we did not have any other options. So you have to cut with the local anesthetic till you see any.
At least part of it. Yeah.
Can I say something?
Yes, Vaishali.
Dr. Anita, you can actually do nasal intubation as well. If the contracture is too bad and neck movements are not to your mark and severe trismus, we can do local full infiltration, local anesthetic, and then can do nasal intubation as well using video laryngoscope. Ambu and which one? Ambu is very good.
So you want to put a oral video laryngoscope?
No, not oral, nasal.
But nasal video laryngoscope?
Blind.
No, that flexi
Flexi bronchoscope, sorry, not laryngoscope, flexi.
Okay. So,
So put the
fiber optic
infiltrate everything.
most of the times you put nasally only.
So we can use that also if the trismus is too bad or severe contracture of neck.
Even if it is not bad, nasal is preferred route because it is a stable. I mean, doesn't come out easily, and the nasal passage a very good conduit for the fiber optic scope.
Yeah, and you can use that Smith ivory tube. So it is very soft and nothing means the chances of trauma are also less in that.
Yes.
So Smith ivory is it's an opaque tube, little turquoise color, not the usual PVC Portex one. It is very soft tube, and it's a turquoise color tube.
Yes, I have seen it long back. That was not.
It is absolutely non-traumatic and very good. And you can just railroad through flexing.
Yes, but they were uncuffed tubes, what I have seen.
No, they are cuffed.
Okay.
Cuffed. Okay. Thank you.
Can you please repeat the name, Vaishali, madam?
Yes.
Name of the tube.
Swiss ivory, she said.
Okay. Yeah.
This is a light bluish color, soft tube.
Specially made for something like
there is North Pole tubes, so nasal tubes, specially made for nasal route.
Yeah, it is Smith ivory. Smith ivory. Sorry, there was some.
Smith
SMITH ivory. IVORY.
Hello, ma'am. This is Dr. Naina Kulkarni. I have used that ivory tube and it is really very good.
Hi, Naina. Yes.
Hi. Ivory tube are very good preformed tubes, but since they are preformed, the neck and all the distances should be proper. Otherwise, the tube cannot be fixed properly. That is one of the drawbacks. Thank you.
Actually, the drawback of this preformed tubes is that according to our Indian patients' measurements, so they are a bit longer. They tend to remain slightly outside.
Don't you think, madam, the RA tubes are better, like North Pole and all those?
RA is a South Pole, madam.
No, North Pole I'm talking about.
For nasal intubation?
Yeah.
Any tube, madam. Nowadays, we actually use armored tube so that, any position, anywhere.
Armored is the best, yeah.
Really available, yes.
Yeah. Silicone North Pole I found better because the material is so soft that there's hardly any resistance to that. Yeah. Can I have a question to Dr. Balaji, sir?
Yes, madam.
Sir, what is the benchmark for the patient of MI to be get operated? Like how long the patient can be safely operated? How long after?
After MI? Madam, it was previously thought, or there was one paper, if you operate within 6 months, there is a high chance of mortality. But nowadays, we are operating once, there are two aspects to this question, for whether you want it for non-cardiac surgery or cardiac surgery. As far as cardiac surgery, we are operating them immediately once patient gets stabilized, maybe within 3-4 days, once there is no enzyme leak and the patient is clinically stable, no element of failure is there, we immediately go ahead with the surgery because it is corrective. We are correcting his disease. As far as non-cardiac surgery is concerned, we see means what is the indication of surgery? If it is a hernia surgery or if it is a not urgent.
So the patient has got the melena and she's been bleeding somewhere in the abdomen and her hemoglobin is always 4 to 5. It never comes up beyond 4 grams in spite of giving transfusion twice a week. Like she needs so many transfusions, but they could not find any cause.
Yes, madam. It is like a semi-emergency situation, and once there is no active enzyme leak, patient is clinically stable, and there is no element of cardiac failure, we can go ahead with the surgery.
How long after?
Maybe after 5 days to 7 days.
With recent MI?
Yes, recent MI, because this is a semi-emergency. If you don't operate, patient is going to die with melena. Only thing is that we have to upgrade on our monitoring system. Means we might have to go with arterial line monitoring, CVP monitoring, aggressive inotropes, fluid management. We don't want hemodynamic fluctuation. Any hemodynamic fluctuation, patient can again land on MI. That care we have to take during managing this patient. But in this sort of semi-emergency, we have to explain the risk and go. Even there is no need to go for coronary angiography. What are the diseases? First, you try to treat this emergency. That Malina part.
Is as good as operating her in a cardiac setup.
Yeah, you have to operate in a tertiary care center where all facilities are available.
So, are there any risk stratification indices like which we can commonly think of if the patient comes for PSC?
Yes, madam, there are so many Duke's classification and all. American Cardiologist Society has given so many indications. We just have to, and thanks to nowadays, they are available on apps also. Means you have to just feel how many days back am I, how much is here, how much is serum creatinine, whether enzyme leak is present. Immediately they certify the patient, how much is the risk. That everything is there through app form.
So you are talking about NSQIP?
There are multiple, madam. Yeah, one of them is NSQIP.
Yeah, they give the ready.
Yes.
Madam got muted.
Yeah, I want to ask a question to Dr. Balaji. I didn't understand the diastolic dysfunction and diastolic failure. I didn't understand the difference. And because many times the grade 1 diastolic dysfunction is written on all echoes.
Yeah, that's what even for every echo there is grade 1, grade 2 diastolic.
Madam, diastolic dysfunction is first degree, second degree, and third degree. In third degree, there will be a diastolic heart failure. There will be a frank sign of failures. Patient will have raised JVP, patient will have fine grade, patient will have reduced saturation, baseline saturation, patient will have edema feed. These are the patient with diastolic heart failure. Another extreme category is just somebody is writing on, suppose a patient is having a hypertension since 10 years, 20 years. He has got just initial diastolic dysfunction where there are no signs of failure. Patient's effort tolerance is also good, but still there is an initiation of diastolic dysfunction occurred in that patient. It won't have that much significant. Second category is bit tricky, means here it is no patient will have a history of dyspnea on exertion with moderate. The patient climbs 1 or 2 flights and he feels breathless. Patient will have, suppose patient travel a bit and he will have edema fit, more edema fit. Patient will have a symptomatic chronic cough due to this diastolic dysfunction. Patient will have, if you hepatocellular reflux might be present. If you press on the liver, this neck veins will get full. These patients are a bit tricky, and in this patient only you, as a clinician, you have to assess how much is the severity of diastolic dysfunction. Ideally, every cardiologist must comment on the degree of diastolic dysfunction on echocardiography. But unfortunately,
mild,
these things...
Mild or something there right
Mild, you don't have to worry. Only thing is that if there is a mild dysfunction, you avoid excessive tachycardia, avoid too much of fluid. This can be, these measures can be taken. But there is no need to worry about mild degree of diastolic dysfunction. This is very common. Any hypertensive patient can have a mild degree of diastolic dysfunction.
There are questions in chat actually for Balaji sir.
Bhatkar madam?
Yeah,
Bhatkar
sure.
madam?
Yeah.
I have one question for Balaji sir.
Yes, ma'am.
Good evening, sir.
Good evening, madam.
Yeah, usually in 2D echo, in old patients specifically, they mention aortic stenosis, tricuspid regurgitation. So how much seriously we should take it while giving anesthesia to these patients?
Madam, mild degree of any valvular heart disease with no symptoms or signs.
No valvular heart disease. Patient is old patient, posted for some other surgery, non-cardiac surgery, and usually we do 2D echo. So the 2D echo mentions mild aortic stenosis or mild aortic regurgitation, something like that. So how seriously we should
Calcified
take it?
aortic.
That is what I'm trying to tell you. Any heart disease like valvular heart disease, aortic stenosis, in a mild degree, is a very common entity. And
Yeah.
if patient is asymptomatic, patient is there are no signs of any failure or any affection due to that heart disease. One don't have to worry about it. Suppose one patient on echo it has written mild degree of aortic stenosis, but patient is walking 5 kilometers a day. It won't going to give any effect during anesthesia.
Right. Okay.
But if it is a moderate degree, patient is symptomatic, history is very, very important. That is why clinical correlation with echo report, clinical correlation with patient symptoms, that there
Type of
is the
surgery
real skill.
or type of surgery.
Most of the time what happen, we don't ask history, we just see the echo, we just see all patients investigation, whatever is written on the paper, and we go ahead with and we landed in so asking history of the patient clinically, you must see how much is the heart rate, how much is the blood pressure. In value 120/80 is the blood pressure written on, and we also accept it. But we must see his blood pressure beforehand. It is most of the time it is 200/120, and in paper it is written 120/80. So naturally, the person who is having 200/120 blood pressure has got many problems. One has to see like that.
So you mean these are the patient's factor as well as surgery specific factors which matters
yes.
Generally for the orthopedic. Generally when they come for an orthopedic, 80 years old male or maybe a person who is walking and is a farmer suddenly falls and he comes for the hip surgery. In that case, many times we come across with aortic stenosis, tricuspid rigidity and the diastolic dysfunction. This sort of picture in echo.
Yes.
We are talking about that.
Yes, yes.
And he had never measured, I mean, he has never tested for his blood pressure because he had never been to the clinic as yet.
Yes. And many times what happens in clinical, suppose there are no signs of end organ damage. What do you mean by suppose patient fall down and during this stress period, his blood pressure has increased. There is no history of hypertension. Just see on ECG whether that P wave present in V1 lead, whether that is bifid P wave. It indicates that patient has got a chronic hypertension. Sudden stress-induced hypertension, no history of hypertension, no history of, as madam told, patient is farmer, and now his blood pressure is maybe 180/100. And we can accept this patient because serum creatinine is also normal. There is no end organ damage. That stress-induced hypertension is there. We can very well go ahead with the surgery. Another problem comes when there are patients, suppose osteoarthritis patient comes for surgery where you don't able to assess his effort tolerance. Just asking simple question, do you feel breathless after bath? Do you feel breathless after taking household work? This question one. Secondly, see how many comorbidities has patient. Patient don't have any comorbidity. With simple osteoarthritis posted for come to us, there are less likely chance that patient will have a coronary artery disease. But the same patient has got a diabetes since 20 years. Patient is obese. Patient is hypertensive since 10 years. Means more than 2 or 3 comorbidities. This patient is likely will have a coronary artery disease. In this way, you have to means everything is, I always feel clinical history is the important, and correlating this with whatever lab is there. This is the important for anesthesiologists.
Dr. Balaji, can I say something if you don't mind?
Yes, madam.
Maya, you just asked about aortic stenosis. You know, as you grow, everybody will get sclerotic or calcified aortic valve. So what they should do, like we should see the gradient across the valve and how severe is the aortic stenosis or valve area. Accordingly, we should decide. Even most of the patients will get mild TR as they grow old. So we should not worry much. Only thing, the specification should be towards valve pathology should be given in echo report. And about diastolic dysfunction also, the third degree is restrictive, which is more severe from anesthetic point of view. Like, and that we get mainly in EF of less than 30% patients. So 30, 35.
And mostly the patients are symptomatic in that case.
Yeah.
Balaji sir, can I ask something?
Yes, madam.
Yeah. Among indices you said like about the MET and DASI score. So which is more important for us, for the patient to go ahead with the surgeries?
I always feel, madam, MET assessment is very, very important for any patient. When you cannot assess the MET, then you have to see what are the other clinical factors that point out towards the presence of severe heart disease. And in that case, all that comes. But you must ask patients clinically, how is his METs? If his patient is having METs of 8, 7, or 9, you don't have to worry, because that much stress patient is easily tolerating during his day-to-day life. You can easily go ahead with the surgery.
That is easy to assess. I mean,
Yeah.
it's quite easy compared to DASI.
Yes, yes.
Can you just name other indices for the members' knowledge?
Dukes I am using, madam, most of the times.
Okay.
Then commonly I am using Dukes. Okay. Otherwise, I think what you have told, NSQIP.
Okay.
Yes, that two indices are most commonly used.
RCRI, sir? RCRI?
I am not using that one.
Okay.
Okay, there is a...
Is there any question in the chat box?
Any questions from the
Audience?
Audience?
They can unmute themselves and can ask directly.
I think everybody has got enough.
Saturated. Of course, sir, your cases were so good. Like they're really, when I heard of that TURP, the bottle getting cracked, and embolism, a huge embolism that we had never thought of. I mean, that would have been never dreamt also by anyone. But these are the ones who really may happen like that. And all other cases you told, fantastic cases, sir. And
thank you.
Yeah,
thank you. Thank you. Rajesh sir, would you like to share something?
One question is there in the chat box. What about the antiplatelet and anticoagulant?
It itself is a very big topic, and I can answer, but I think it itself is a very separate and very big topic, because it depends on so many factors. Means when angioplasty has done, which stent has been put, which antiplatelets are there, and if he can, I will forward him everything.
So,
yeah,
okay,
please do share, sir, if possible. That may be a common query all the time about the platelets and when to withhold them and what happens for the surgeries. Next.
Yes, madam. Basically, you have to see which stent has been deployed. Most of the time nowadays, we are drug-eluting stent is deployed. Basically, what do you mean by drug-eluting stent? There will be some drug release, anti-cancer drug release through that stent, so that there will not be an endothelialization of the stent. This may last for 6 months. So during that 6 months, patient must take two antiplatelets very rigorously. If patient stop these two antiplatelet, there will be a sudden instant thrombosis occurs, and which has got the highest mortality. It has got a 90% mortality. Suddenly, that stents get blocked. Naturally, for any surgery, elective surgery, after coronary angioplasty, you cannot stop two drugs for at least 6 months. It was previously at least it was 1 year, but nowadays they're saying at least for 6 months you must not stop these two antiplatelets. Secondly, you have to see how emergency is the surgery. Can you wait for surgery for 6 months? If you don't, then you have to see risk and reward. Means stopping that two drugs, or either stopping one drug and continuing with just plain aspirin and going ahead with the surgery. You have to judge as per the surgical requirement of the patient. Suppose this patient has to go very simple surgery like gastroscopy, like cataract surgery. There is no need to stop these drugs. But suppose same person is want to go for some cranial surgery, means craniotomy or closed ENT surgery, you need to stop these drugs. So it is not a very easy answer for this you do practice. But basically, you must remember, if patient has gone with antiplatelet with drug-eluting stent, you cannot stop this for at least 6 months. Then only then in high-risk cases, suppose patient has got a very severe kind of coronary artery disease and left main stenting has done, osteal LAD stenting has been done. It's very, very risky to stop 2 drug antiplatelets which are on board in this patient. So you may have to stop only one agent even after 6 months and go ahead with the surgery. So it depends. It itself is a very big topic. That is why I was avoiding this. It requires a separate session, or there are so many ifs and buts while stopping these antiplatelets.
So just one word, like a cataract surgery, it is always a query when to stop clopidogrel for how many days, and should the aspirin can be continued. So that is
aspirin can be continued. Even we are nowadays when there is patient is on aspirin, still we are giving regional anesthesia, spinal anesthesia. Nowadays they saying because why this is because aspirin is very low antiplatelet agent. So it is very less likely chance that when aspirin on board, there are chances of hematoma or excessive bleeding. But this is not the case with prasugrel. This is not the case with clopidogrel. So one has to stop clopidogrel, but aspirin can be continued.
Yeah.
Okay, I think
can be stopped 5 days prior.
Yes, madam. Again, there are ifs and buts. Why 5
No,
days?
the guidelines say 5 days, and then you can go ahead with surgery. But as you said, aspirin you can continue,
Yes.
but even if patient is going for surgery.
Yes. Once you take this clopidogrel, its action lasts for, action immediately acts on all the platelets in the body. And every platelet, almost 1/7 of the platelets are regenerating daily. So why 5 days? After 5 days, there will be a sufficient number of platelets which are not under the effect of clopidogrel, or that is why 5 days has come. For suppose, but this is a very critical patient has got a very severe form of coronary artery disease, as I already told. Osteal LAD has been stented. It's a very risky to stop clopidogrel. Maybe after
Listen, Dr. Balaji, once it is stented, there is not a problem. If it is stented, there is no problem. And he already has got clopidogrel in his system. So we can...
No, that is why, madam, I am telling you, once it is stented, but patient has got a big stent, and patient, if you stop that clopidogrel suddenly in this patient, there are high chance of instant thrombosis. That also we don't want. Suppose there's LAD.
It depends on when you stopped it. When patient had plasty and when you are going to stop it for surgery.
That is why I am telling. Within 6 months, I am trying to tell you. Okay. If it is after 6 months, there is no problem. You can easily stop for 5 days.
So any surgery, like elective surgery, should be avoided within 6 months, you mean to say?
If possible. But as you said, like melena, patient is suffering from melena. We have to go ahead with the...
I think
treat more with clopidogrel again.
Yes, it's more with clopidogrel.
When we should start the clopidogrel after the surgery? The patient is without stent, but he is on aspirin and clopidogrel. We have stopped the clopidogrel 5 days before, and how many hours?
Once surgeon feels that there is no risk of re-exploration, bleeding, or type of surgery, it depends. But invariably, they start it after 24 hours. Once there is no drains, once everything is settled, usually after 24 hours, they usually start with the antiplatelet. But in cardiac surgery, we are giving aspirin immediately after shifting the patient, maybe within 2 or 3 hours. Once there is no drain, we immediately give the aspirin to the patient, and at evening or at late night, even we give clopidogrel to this patient.
Is there any chance to start the low molecular heparin if we cannot start clopidogrel immediately after the surgery?
Yes, there are bridge therapy, what we call in those patients where there are high chance that starting clopidogrel may jeopardize this. You can go ahead with a low molecular weight heparin.
That we can start within an hour or within 5 to 6 hours.
Yes, within maybe 5 to 6 hours.
Dr. Asegaonkar.
Yes, madam.
One thing I just wanted to ask you is that nowadays the ophthalmologists were doing clear corneal surgeries. They don't even stop that clopidogrel tablet if the patient is on clopidogrel.
Madam, if there is no risk
सर
of
एक 5
bleeding
मिनट
in
10
that
मिनिटांनी फोन करून
surgery,
एक मिनिट
if there is no risk of bleeding in that surgery, means cornea, I think, is it avascular avascular area where there are less chances of blood vessels. In that case, you can go ahead with when both antiplatelets on board.
And can we get that name of that app which you mentioned?
Duke's app, madam, Duke's.
Duke's.
If possible, I will put on your, I will share with Maya madam or your Gatkar madam.
Thank you, sir.
I think with this interesting topic, discussion is never ending, I believe.
Yes, yes.
So let's.
That's the last question. When is the referral to the cardiologist? When is the possible referral to the cardiologist? Last question.
Madam, when you think there is high chance of cardiac disease or cardiac comorbidity is present, then and then only patient should be referred. Not that every patient nowadays, every patient undergo echo. That is not a good practice. You must, suppose there is one farmer who is working in farm, daily in farm, maybe for 2 hours, 4 hours. He has got all echo, everything is clinically good, lab is good. There is no need to refer these patients to the cardiologist. So it is said that if MET 8 or 10 is there is no need to ECG also. These patients can directly subject for any surgery without doing even simple ECG. This is what the recommendation is. But nowadays, for our safety or whatever it may be, or due to phobia of the cardiac diseases, we refer each and every patient to the cardiologist. Similarly, whenever as an anesthesiologist, you feel patient have got cardiac symptoms, when patient has got signs and symptoms that suggest that there is a strong possibility of cardiac disease, you must refer them and you must ask them to give opinion about the severity of the disease. Most of the time what they write down, hypertension, blood pressure, so and so, and very less likely that they will see towards the end organ damage, whether there are presence of end organ damage is present or not. That as an anesthesiologist, you must see whether that end organ damage, hypertension has produced or not, and then only you take a call.
Yeah, thank you, sir. So at the outset, I take this opportunity to madam.
Bhavesh, can I take a few minutes? A small announcement on behalf of Dr. Balaji Asegaonkar sir and Dr. Rajesh Tagatpalle and whole SAMS team, Dr. Anita madam and all. We are having a Diwali Dipotsav, Suramayi Mangalmayi Dipotsav on 12th November, and I request all of you to join for that महोत्सव. दिवाळी पहाट आपण म्हणूया, पण त्याला आपण दिवाळी पहाट न म्हणता आपण ते 11 वाजता करतोय. दिवाळी सकाळ आपण करूया, ती रम्य सकाळ आपण करूया दिवाळीची. सो सगळ्यांना रिक्वेस्ट आहे की एव्हरीबडी शुड जॉइन दिवाळी पहाट.
That's on the 12th Sunday.
12th November
Sunday.
First day of Diwali.
Yeah, first day. Second day.
First day, madam.
That is Narak Chaturdashi.
Yes, Narak.
Dhanatrayodashi is on Saturday. Yes.
So on behalf
Thank you
of
so much. Thank you.
Thank you,
I
madam.
wish happy Diwali to all bearers, office bearers from the SAMS and all members of the SAPC and all others, those who are logged in. I wish them very happy Diwali and happy days coming ahead. Thank you.
It was very nice that we couldn't do this function offline. Actually, we wanted to invite all SAMS office bearers to our branch, but it was not possible. So we thought we should invite on webinar, at least webinar platform. So we took this decision and we invited you. Thank you so much for joining.
Yes, madam. We have also really enjoyed this. Thank you very much.
Thank you.
Thank you, SAPC. for the very first
Anita
webinar.
madam, one question was asked, like how many days you can wait for the scoring, not to having worry about the hyperkalemia. How many days? Is there any guideline for the?
Yes,
She has already mentioned, I think.
yes, it was there. It is 1 year, but you can actually use after 6 months. And what they say is it depends on whether the patient is ambulatory or not. So if a patient after 6 months is doing all his work and his contractures are released, he is functioning well, then the upregulation reduces. So, but if the patient is bedridden, then it takes longer. So from 48 hours to 1 year, they say.
1 year. She had already mentioned in her slide.
Yeah,
Yes.
yeah. There was a question. Thank you.
Thank you so much. Thanks.
Thank you, Balaji sir. Thank you, Nete madam.
Thank you.
Thank you, Tagadapalle sir, Katikar madam, and all the senior faculties. Thank you, Maya madam. Thank you, all our Seema madam, Sumit, and everybody. Please, thank you for joining. And I think I conclude that the session is over.
Yeah,
Thank
hope
you
we
very much.
meet soon on offline.
Thank you, Janika, for the platform provided. Varsha, yeah.
Thank
Yeah,
you.
madam.
Thank you.
Thank you. Happy Diwali to all. Thank
Happy
you.
Diwali. Yes, happy Diwali.
Happy Diwali. Happy Diwali in advance to everybody.
Enjoy. Yes,
We'll
yes.
meet on
Really enjoyed the session.
Diwali Sakal.
And don't forget to log in on 12th.
Yes, we will log in.
We really enjoyed
Okay.
this session, as well as we'll be enjoying the Diwali part, as Maya said. Okay.
Big congratulations to SAPC.
Thank you, sir. Thank you very much.
For conducting
Thank
a
you.
very good webinar.
Yes.
Thank you. Bye.
Thank you,
Bhavesh, Shobha madam, Maya
Yeah,
madam.
thank you, ma'am. Yeah. Nice seeing you. Bye.
Bye.
Thank you.
Bye.